The speaker for this presentation is Rolando Claure-Del Granado.
Good morning, and thank you, Ravi, and organizing committee for inviting me to talk about the strategies of CRRT for treating COVID-19 patients and the experience we have so far in Latin America. I'm also want to thank you, the SLAN AKI committee, for providing me with the information I'm gonna present, and that's preliminary information. In the following 15 minutes, I'm gonna discuss the following points. I'm gonna show what is the Latin American region and show its fragmented healthcare systems that have an impact during this pandemic. What's the actual situation of COVID-19 in Latin America, the epidemiology of AKI in the region, and finally, what are the renal replacement therapy resources we have and what we have been doing for treating patients with AKI and COVID-19 who require renal replacement therapies in the region. So Latin America consists of 20 countries and 14 dependent territories. It covers an area of approximately more than 19 million square kilometers. It covers 13% of the Earth's land surface area, and by 2018 it had a population that was estimated in more than 642 million people. There are a lot of disparities in Latin America. By 2014, Latin America had a combined GDP of 5.5 million US dollars, but per capita income is very heterogeneous. You could have a per capita income in Chile that is higher than 15,000 US dollars, and you have per capita income in Haiti that is just of $719 per year. Life expectancy also is very heterogeneous. You could have a life expectancy of 53.1 years in Haiti, and in Chile it could go as high as 79.3 years. And also health expenditure is very heterogeneous. You have countries like Chile where health expenditure is more than $4,400 per person per year, and countries with low income like Haiti where government just spent less than $24 per person per year in health. Also, the healthcare systems in our countries are very fragmented and divided. And this usually happens in most of the countries. I'm showing how the healthcare system is divided in Bolivia. You have 30% of the population who has no health insurance and has to look for healthcare in public and government-run public hospitals with low resources, low number of physicians, nurses, and sometimes with no enough medications or needed medications. 30% of the population goes to this short-term insurance. These short-term insurance are for patients, for people who have a independent or dependent work, and it also benefits their direct families. 30% of the population has no insurance at all, and they usually use traditional or herbal medicine or go to small clinics run by the church or non-governmental organizations. And 10% of the population are able to buy private insurance and are a small part of the populations with better access to better equipment, hospital, clinics, and access to medications. What's the problem of COVID-19 in Latin America? Well, by June 2020, in Latin America and the Caribbean, was the latest world COVID-19 hotspot. By June of 2020, 27% of deaths due to COVID were in the Latin American region. And cases are still growing. And factors for this explosion in cases and deaths are that we have constrained health systems, we have high prevalence of chronic conditions, and we have delayed responses due to populist governments in the region. And also is the factor that widespread poverty and inequality. Here you could see that in the top list of countries with reported cases that was checked 2 or 3 weeks ago, 4 countries of Latin America appear in this list: Brazil, Colombia, Argentina, and Mexico. And also in the top 15 countries where of deaths due to COVID-19, 5 Latin America countries appear: Brazil, Mexico, Colombia, Argentina, and Peru. And these are the examples of why COVID-19 was a problem in Latin America, and what was the role of governments for these increasing reported cases and reported deaths. For example, in Brazil, Bolsonaro, after the President Atena meeting in the US and 24 members of his delegation test positive for SARS-CoV-2, President Atena public rally. And the president continued to encourage people to go out and resume their normal lives. In Mexico, Andrés Manuel López Obrador, for example, is always telling that this is not even bad as the flu. He is continually urging Mexicans to visit restaurants or to continue with their normal lives. In Nicaragua, Vice President Rosario Murillo, who is coordinating the response to the pandemic, declined at the very beginning to close schools and shops, and even the local soccer league was not being suspended as other countries have done before. So what is the epidemiology of AKI? And we will compare the epidemiology of AKI related to COVID to non-COVID cases. We don't have much data in the region. One of the best studies was published last year, was an observational prospective longitudinal multinational cohort study. It's the EPILAB-ERA study that was done from November 2017 to July 2018. This study was done by invitation through the SLAM webpage, email sent through our Ready-ERA network, and through local societies of nephrology. We include all adult patients and children with confirmed AKI, and we exclude patients with end-stage kidney disease, chronic dialysis, and kidney transplant. 15 countries of the 24 countries that are members of SLAM participate. We were able to enroll 905 patients, and data was introduced online by participants through a secure online platform. You could see that the list of the participant countries here, and the number of centers that participate, and the number of patients that each country were able to include. As other studies of community and hospital-acquired AKI have shown, most of the patients have a risk factor, and the common risk factors for AKI were age, CKD, diabetes, anemia, chronic heart disease, and chronic liver disease. You need to notice that most of these risk factors for AKI are also risk factors for AKI in COVID-19 patients. Only 176 patients didn't have any type of comorbidities. Regarding to the etiology, dehydration, shock, and the use of nephrotoxins were the most common etiologies, either in community-acquired AKI and in hospital-acquired AKI. However, community-acquired AKI was most common as a cause of the AKI rather than hospital-acquired AKI. Kidney replacement therapy was required in 36% of cases of hospital-acquired AKI and just in 22% of cases in patients with community-acquired AKI. In hospital, mortality was high, 20% in community-acquired AKI, and 43% 3% in patients with hospital-acquired AKI. And what about if we compare with COVID-19 patients who develop AKI? We have this Latin American registry that was submitted as an abstract to the World Congress of Nephrology, and will be presented in 2021. We were able to include 632 patients. The median age was 63 years. Most of them were male, and at least one comorbidity was present in 86.9% of the patients. The most common comorbidities were hypertension, diabetes, and obesity. As compared to AKI non-related to COVID, in this case, hospital-acquired AKI was more common. Almost 60% of the patients were diagnosed with hospital-acquired AKI. Most of them was non-oliguric AKI. And the causes and the etiology, the number cause was related to COVID and cytokine storm in 56% of the patients, hypovolemia in 38% of the patients, and the use of nephrotoxins in 26% of the cases. That is different from what I have shown before. The patients with COVID-19 and AKI require renal replacement therapy in 47.2% of the cases, higher dialysis requirement as compared with non-COVID AKI. And the most frequent therapy use was IHD. The second most frequent use was PIRT. The third one was CRRT. And the fourth one more used was PD, with a high mortality rate of 57.4%. Higher than the mortality of hospital-acquired AKI and community-acquired AKI in non-COVID-19 patients. What about the resources of treating COVID-19 patients and for treating AKI that requires renal replacement therapy in the region? We have data from this survey that was performed in 2012 in 14 countries of the region, and we wanted to collect information about human resources, available infrastructure, renal replacement therapy, and equipment for AKI. 246 renal replacement units participate. Unfortunately, most of the information came from 5 countries that were Argentina, Brazil, Chile, Peru, and Uruguay. And most of the units were located in university hospital and were part of divisions of nephrology. We have low resources for treating AKI, less than 5 nephrologists and nurses for the care of patients with AKI who require renal replacement therapy. And the causes back in 2012 were quite different from the causes of AKI in our most recent study. And back in 2012, septic abortion, hemolytic uremic syndrome, diarrhea, and leptospirosis were the most common causes of AKI. In terms of renal replacement therapy available for treating AKI, most of the units were able to provide IHD. Only 40% were able to provide PIRT, 30% were able to provide PD, and just 23% of the dialysis unit were able to provide CRRT. What about COVID-19? We have been reading these papers, these consensus and recommendations from groups like ATKI and CADIGO. And there's very interesting contingency plans and crisis plan modes and plan out when your conventional operations are running. This is good, and this is I'm pretty sure that works in high-income countries. Unfortunately, in low-income countries where more countries in Latin America are located, we always work on a crisis plan mode where we have to use different types of renal replacement therapy to provide these therapies to patients with AKI, and we have to use mixed types of CRRT, mixed types of IHD, PIRT, and PD. So we work on this crisis plan and crisis mode always. And this was not different during COVID-19 pandemic. We have gathered together a group of experts of the region and have proposed different strategies to provide renal replacement therapy in Latin America. We agree that CRRT is the therapy of choice for these patients, since most of them are hemodynamically unstable patients. This type of therapy may provoke fewer episodes of hypotension, might improve early renal recovery, will provide more effective management of marked fluid overload, etc. However, there are some disadvantages, like advanced technology required, especially trained healthcare personnel that we usually don't have. This type of therapy is not usually available in all centers in Latin America and is very expensive therapy. So what we have proposed is the following algorithm. Once you see that a patient with COVID-19 and AKI requires renal replacement therapy, your type of therapy selection should be divided once you have a patient who is hemodynamically unstable or is hemodynamically stable. In the first case, your selection should be based on the local equipment availability, on the supplies you have, and the local expertise. And therapy of choice, we agree, is CRRT. If you don't have this type of therapy, the second choice should be period. And if you don't have this type of therapy, you should choose PD. We have made some recommendations in terms of prescription. And if you have an unstable patient, you either could choose ISD or PD, with some recommendations we have provided. One of the types of CRRT we have been using in Latin America due to the shortage of supplies, personnel, etc., is using CRRT devices for 8, 10, 12 hours. And we use this modality, CBV-HFD. That will allow us to use high flux membranes, and the use of high flux membranes will provide clearance of higher molecular weight inflammatory mediators in these patients. And we have the opportunity to use one CRRT device for treating 3 or 2 patients per day, and to move our device to different hospital zones where available water is not feasible, and the use of portable osmosis and therapies like intermittent hemodialysis and ISD is not possible. We have modified our heparin protocols, and that has allowed us to provide adequate renal replacement therapy to our patients. So in conclusions, increased poverty, limited water access, poor sanitation, and distrust in governance are important factors that have affected the transmission and have facilitated COVID-19 outbreaks in Latin America. What we know so far about AKI in COVID-19 patients in the region, that most of the AKI is hospital-acquired. Almost 60% of patients had indications for starting renal replacement therapy. ISD is the most used type of renal replacement therapy, and we will need to better use CRRT for the next outbreaks, and we need to train more personnel. We need to buy more devices of CRRT for the next outbreaks. The 3 main causes of AKI were cytokine storm, hypovolemia, and nephrotoxicity. Unfortunately, only 30% of patients recover renal function after an episode of AKI. Now we have all types of renal replacement therapy available in Latin America for treating COVID-19 patients with AKI. And in the region, we have developed and adapted therapies such as CRRT in order to provide adequate treatment for limited resources. And with that, I will finish. Thank you.